Good morning, everybody. We're so happy to have you join us today. My name is Sharice Magoon, and I'm with UT Health School of Nursing. You are signed in to hear Dr. McGrath presenting Engaging Families in Feeding and Nutritional Support. We're happy to have you join us for the Texas NAS Awareness Month. These free CE presentations are sponsored by Texas Health and Human Services. Before we get started, let me go over a few housekeeping items. Please mute your microphones and also make sure your video is turned off. We will take question and answer through the chat today. I'd like to introduce you to Jacqueline McGrath, PhD, RN, FNAP, FAAN. She is the Vice Dean for Faculty Excellence at UT Health San Antonio School of Nursing. So proud to have one of our faculty presenting today. Dr. Jacqueline McGrath is the Thelma and Joe Crow Endowed Professor and Vice Dean for Faculty Excellence at the UT Health San Antonio School of Nursing. Dr. McGrath is an excellent scholar and teacher. She has mentored more than 20 PhD students among more than 50 mentees at all levels across her career trajectory. Research includes integration of family-centered and developmentally supportive caregiving with high-risk infants and their families in the neonatal intensive care unit. More specifically, her work has focused on the biobehavioral outcomes related to increasing parent engagement for both parents and the infant. She has also conducted studies related to oral feeding readiness and infant touch and massage, parent provided. Based on her research, she developed the NICU Play program for parents and their hospitalized infants. She is well known in the field for her scholarly publications with more than 130 peer-reviewed articles, 100+ editorials, and short manuscripts, as well as more than 35+ book chapters. Since 2014, Dr. McGrath has been the co-editor for Advances in Neonatal Care, the journal of the National Association of Neonatal Nurses. She is also the co-editor for Developmental Care for Newborns and Infants, a guide for health professions, 2nd edition. The 3rd edition of this book is in development. In 2007, Dr. McGrath became a fellow of the American Academy of Nursing. She has also received the Lifetime Achievement Award from the National Association of Neonatal Nurses in 2017. As a truly excellent mentor and teacher, Dr. McGrath believes leadership is seeing the brilliance in other people and creating joy at work is central to success. Without further ado, I'll hand it over to you, Dr. McGrath.
Thank you so much, Sharice. It's great to be here this morning. I want to thank you and Dr. Lisa Cleveland for putting this conference together, this webinar, and for really all the work that Dr. Cleveland has championed across the state of Texas. It's really an honor to be among her team and working on these projects. So I don't really have any conflicts to report. As was said already, I am the co-editor for Advances in Neonatal Care. We did actually get a 5-second segment on Grey's Anatomy where our journal was there, so I always like that picture to show that. I also was part of a FAAN, the Vermont Oxford Network initiative in 2014, which was focused on drug abuse and babies who had been exposed prenatally to drug use and opioids. And so many of the slides or some of the work that I've done came from some of that work with the Vermont Oxford Network, and I wanted to share that. So we all know that what the clinical features of NAS are, and we have there are many things that make us concerned about feeding these infants. The neuroexcitability, all of the behaviors that they have, But I think what's really interesting in the focus for today's presentation is, how does this affect the GI system and feeding, and what could we be doing differently to better support these infants and their growth and development. If we're really thinking about long-term development, we have to also think about growth and whether there is energy left for learning, for really growing in a particular way. And if all the energy is just concentrated on managing these symptoms, then there's less likelihood that there's going to be something left over to focus on development. And so when I think about this slide, I really want you to think about how the behaviors, the risk factors, the other pieces that occur with opioid exposure affects across all the neurobehavioral systems: autonomic, motor, state control, sensory integration, which then affects not only feeding outcomes, but then parent and infant outcomes. I long time ago wrote an article about how parents judge whether they're being a good parent or not. Being a good parent is about whether your baby is growing and whether your baby is achieving their normal milestones. So parents will often be asked about how they're doing with their infant, and their answer is, well, he's almost 10 pounds. So that idea that he's almost 10 pounds shortly after birth says to me that feeding is really an important part of what's going on in that relationship. And so if they're not being able to be successful with everyday feeding routines, then that's going to impact everything about how the mother and infant relationship is developing. So when I think about the physiologic links, and I want you to know that there's not, some of my resources you'll see are quite old. The research in this area is somewhat limited, especially as you'll see when I show you some of those outcomes, especially because this population has really been understudied. And so there's not a lot of newer data really helping us to better understand these infants. And yet, I want to emphasize that the change from 1999 to today is that there are a 5-fold increase in the numbers of infants affected by neonatal abstinence syndrome. And about 50% of those infants, depending on the different areas, or I shouldn't say it that way, depending on the different areas of the country, more than half of the admissions to the newborn intensive care unit could be related to neonatal abstinence syndrome. So it's really important to understand how GI symptoms and NAS can affect the stay, because most of the time growth is one of the areas that limits whether the infant is able to be discharged or whether they need more pharmacologic management as opposed to non-pharmacologic management. So most of the opioid receptors are concentrated in the central nervous system or in the gastrointestinal tract. And many of the signs and symptoms that we look for to decide whether this baby is managing withdrawal are also reflected of that CNS irritability, autonomic overreactivity, and then GI tract dysfunction. And so, as you might guess, thinking about that is that many of these symptoms impact feeding. So it's important for you to remember that excessive environmental stimulation, particularly even excessive hunger, could exacerbate the perceived severity of NAS. And so as we think about how best to manage feeding for these infants, it's important to think about these signs and symptoms. In addition, there are many signs and symptoms of neonatal abstinence syndrome that also impact gastrointestinal dysfunction. For example, many times these infants will have troubles with watery stool, explosive diarrhea. Because of the kind of stool they often have trouble with diaper rash, which can be very painful. They don't want to, be diapered, or all of the extra kinds of care that need to happen with a severe diaper rash. They might have moderate diarrhea, and that can lead to poor weight gain. There is some evidence that these children are more likely to lose more weight after birth than that normal, what we consider to be about 10% of their birth weight. They can become easily dehydrated, and that can lead to failure to thrive. They might be more gassy than other infants, and it might be somewhat cyclic in nature, which of course can lead to increased irritability and crying cycles. And because of the diarrhea and the watery stool, oftentimes that can irritate the lower bowel, and traces of blood may be seen in their stool. So again, thinking about this stress and high stimulation, and how almost it creates its own cycle where one affects the other. And so we really have to think about, how do we kind of break the cycle down so that we don't have this continued distress that can lead to increased GI symptoms. So I already spoke about this study a moment ago a little bit about, they looked at 354 full-term methadone exposed infants and looked at weight loss. We know that the average weight loss for a full-term infant is about 10%. That's what we tell families to expect. And we expect that they're going to gain it back over the first 3 to 5 days. However, with infants with NAS, they can have much more excessive weight loss due to the kinds of stool that they have, due to the way that they're so fussy, and they might actually do more poorly. Now, one of the things that this study points out is that breastfeeding can actually be more helpful to these infants than not helpful. And we're going to talk about that later. These infants are less likely to be breastfed than other full-term infants. And so what can we do to make sure that they're getting breastfeedings, that we're helping mothers to be supported to do that? And how do we do that safely? Because there's a lot of even myths, but even some ideas about, how much drug exposure further are we providing to this infant if we're also providing breast milk. And so trying to understand what are the positives, the benefits, and then what are the risks of providing breast milk. We'll talk about that in a few more minutes. So one of our team, Dr. Kelly McLaughlin-Bell, recently, actually will be published in our next issue of Advances in Neonatal Care, looked specifically at feeding behaviors in infants prenatally exposed to opioids. And what she really wanted to understand is, what behaviors do these infants display? What might we be doing about it? And could we really say this is a feeding behavior that's really related to their opioid exposure, or is it just kind of normal newborn transition to feeding? And I think that what's important to know about this systematic review that she did is that she looked at her inclusion-exclusion criteria were related to purposes of looking at infant feeding behaviors. They had to have samples that included infants with prenatal opioid exposure, and they had to be, published since 1970. And again, that's a very wide range, but you'll see that when she had to do the study, we had to really choose a wide range, because even with choosing that wide range, we only found 4 studies. And so again, that's what I was talking about, how this group is really understudied, and most of our care has been kind of anecdotal, or what seems to work, as opposed to something that's been studied and really does work with managing feeding kinds of issues in these infants. So although started out with almost 7,000 articles that met that search criteria, when we really kind of sifted down through and looked at the titles and the abstracts, and then really read for meeting the inclusion exclusion criteria, only 4 studies met the criteria. And then, so these are the 4 studies. And what she was really trying to understand is, what are the comprehensive problems or things that people found about the sucking characteristics that could be different about truly the feeding. So really looking at, these infants tend to overeat almost. They tend to be almost always hungry. And are we distinguishing what is always hungry from just being always irritable? And how can we support that irritability as opposed to overfeeding these infants? Although they seem to appear to use a lot of energy from all this overstimulation. And so how do we help to find that balance? Because we also know these are children that are losing weight in those first few weeks until we can get their feedings more stabilized. So many of the studies looked at different behaviors, sucking, breathing, really looking at the feeding outcomes themselves, looking at the mother's competence, whether the baby was aroused before the feeding or not, whether they rested well, or how many were actually fussing and crying. So looking more across all of the characteristics to try and understand how those affected feeding outcomes. So given that, I've showed that there's a lot of challenges, and that, of course, we're trying to encourage optimal nutrition. So these infants often have state instability. They can either be hyper alert or really easily agitated, or what I've also seen is awake 1 minute, totally there, and totally asleep the next minute. And so trying to figure out how to manage those that state instability. They also have what I would call an atypical sucking pattern, and that's what was identified in some of those studies, where they're kind of disorganized. They don't really have a nice suck, swallow, breathe pattern. They may be suck, 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 then breathe, then suck, 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 breathe, and so almost very disorganized. And as they're not getting what they want, they're also become more and more agitated, and that disorganization can even make the feeding more atypical. They suck so long that they almost exhaust themselves, and then they don't really pause. It's almost as if we have to pause for them. They do seem to have some increased caloric needs, and many of those are about that GI system dysfunction, where their GI system is also hyper irritable, and that could lead to the ideas that these children also have increased needs. So we need to really think about where we're going with their calories. There's a lot of interventions. I'm going to talk about a few of those later in the presentation, but basically what we're going to try and do is decrease stimulation, support handling and swaddling, and a really consistent approach. Many times these children are somewhat separated when they're in the newborn intensive care unit, maybe put in a quieter area, better than a secluded corner. But these infants, as you'll see when we look at some of the newer interventions, really benefit from a single room design kind of unit where they can be very much in a quiet place, where their families might be able to be with them on a more regular basis so that they can really get consistent handling, support, swaddling, and bring down that stimulation so that when they start feeding, they're already not so over the top agitated that feeding becomes a really difficult intervention. For nutritional interventions, we need to really think about their calories. Sometimes these infants do better on like a high calorie formula. Sometimes, of course, breast milk, we need to think about use of human milk when possible, or getting the mom to be available for breastfeeding. These mothers are as likely to initiate breastfeeding as other mothers. However, they're less likely to be continuing to provide breast milk at discharge. And we'll talk about that more in a study result that I wanted to share with you. They also need to have really good eyes and nose to really make sure that we're trending what's happening so that we can kind of think about, what should we be doing to best manage and augment their calories. These are not the babies you want to wake up to feed. So even though they may have a higher caloric need, we may need to allow them to kind of be on their own schedule and think about what's the best way for that to occur. For feeding patterns, we need to think about, this baby, and I think about feeding as looking at where they're at for that entire day. So, has there been anything? Did they get good rest? What's been going on with their baseline? Do they seem really already overstimulated? What can we do to take the environment down a few levels? The light, the movement, other kinds of interactions in the area. Where are they at with their withdrawal? And do we need to better manage their withdrawal? And is that with both non-pharmacologic as well as pharmacologic interventions? What has their feeding been like in the past? Do they have a disorganized suck, seal, or latch? If they're going to the breast, what is their swallow? Where's their tongue positioned? Is it up on the top of the roof of their mouth? Are we making sure that when we offer bottle feeding or breastfeeding that their tongue is in the right position? Where is, how much of their formula are they leaking out on the sides? In other words, are they really having a good seal? Are they making different sounds? These are things to really pay attention to, what's going on with this feeding. What is the volume that they're taking? Even, it's suggested that they need at least 100 cc's per kilo per day. Some babies take as much as 200. However, we have to be really careful about that, because if we overload the GI system, then we're more likely to have runny stools and diarrhea and more irritability from the GI system. So trying to find that happy medium, because there is this disorganized suck, swallow, breathe pattern, these infants can also take a very long time to feed, 30 to 45 minutes. That's a long time, and that takes a lot of patience. And these are not infants that I would suggest kind of what I would call a force feeding pattern. They really need to be worked with, and we need to make sure that we're not starting with them being so upset that then they're almost in what I would call a hyperphagia, where they're ravenous, they're gulping, they're really, you know, taking as much as they can in. And because there is also with all of that, the chance of increased air intake. So causing that gas that we're talking, you know, that could increase that GI system irritability. So the way that they're feeding, you can see it's like, what is the chicken and what is the egg? You know, is it really that they have GI dysfunction already, or is it the way that they feed that is adding to the GI dysfunction? So really thinking about how all these things fit together. Are they vomiting in between their feedings, and how much? And is it related to their burping or not related to their burping? And is it projectile in nature? And so truly trying to understand how much regurgitation they're having, and what's going on during the feeding, between feedings. So it really does take very consistent documentation over the course of the day to really step back and then be able to reflect on what could we be doing different with this feeding pattern to support it better? How can we make sure that we're really helping these infants to be successful in their feeding? Also, you know, classic symptoms that you might look at for this hyperphagia are, you know, a very high increase over of intake, over 190 cc's per kilo per day. And really thinking about, you know, is there still, even with all of that, is there still an increase in weight loss? Is there an increase in diarrhea? So is it really high metabolic demand, or greater losses, or lack of an effective pharmacologic symptomatology management? So really stepping back and seeing what was happening. So was it associated with maternal methadone dose, or with infant withdrawing scores, or associated with rapid weight gain during the first month of MOT? So I think it's really trying to understand what are the symptoms associated with. So your charting is going to be really important during this time to really kind of understand how much regurgitation there is, how much diarrhea, is there abdominal distension, or, you know, and still is there weight loss with all of this intake, because we're going to try and figure out how to best manage that. That may, even though we're trying to, of course, start first with non-pharmacologic management for these babies may, you know, if they have these high of symptoms, need more pharmacologic management of their withdrawal symptomatology. So when we look at what's going on, you can see that withdrawal can actually increase over time, the need for methadone, and from 26% to 50%, 56%. So it really is important to think about what's going on with hyperphagia, because if it's not getting better, then we need to really think about, do these children need more pharmacologic management? Do we really need to think about what's going on with how do we, you know, get to a better place with weight gain? It seems like this can be so cyclic, and so trying to break that cycle is extremely important. So some of the ways to break the cycle. So we're going to talk a little bit more now. We've talked about the symptoms, but let's talk more about what can we do about it. So some of the first things we can do is really swaddling these babies. We want to try and help them relax, breathe, suck, and swallow. They're going to need support to do that. the picture that I'm going to be showing really is about calming the infant before you start the feeding. Making sure that when you're containing them or swaddling, that you're encouraging flexion and relaxation and comfort. So you're creating a sense of control for that infant and decreasing their disorganization. So swaddling and positioning can really be important with trying to support them. Doing that before feeding as a way to calm them can also be extremely important. So in this picture, you can see, I think this is a really great picture of someone just kind of getting the baby positioned, holding them, and just kind of waiting to see how calm they can be and getting them calm before picking them up and trying to start the feeding. This can be extremely difficult to do. These infants usually wake up and they're so agitated. And yet we know starting to try and feed them in that agitated state really just almost exacerbates that cycle. So really trying to calm them and get them more ready for a positive feeding experience. So one of the newest models that's out there to try and really work with infants who are experiencing neonatal abstinence syndrome is Eat, Sleep, and Console. And I'll bet most of you in the audience have heard about Eat, Sleep, and Console. This is truly a family-centered model of treatment for neonatal abstinence syndrome. So when I first heard of Eat, Sleep, and Console, I thought it was more about what the nursing staff did, that it was more about we're going to help them eat and sleep. We're not going to wake them up between feedings. However, as I became more and more familiar with this approach, I realized that this is all about getting the family involved and all about helping them be a part of what is the model, the strategy for caregiving. So it's helping them to understand their baby, to read their cues, to really understand when is the best time to do that. But Eat, Sleep, and Console itself is fairly new and not as well studied as we would like it to be. So there's only been a few studies published. This is an article that was published in Advances in Neonatal Care in 2019. So the 3 studies that are there are from 2018. I'm now seeing more people use Eat, Sleep, and Console and looking at it from a quality improvement model as opposed from a research model to try and look at, so what are we doing to best support families and how do we help them to really manage and work together with their infant. So this is a non-pharmacologic intervention. It's a bundle usually of different ways to work with both the infant and the family and supporting that family. The great news about the treatment so far, it does seem to decrease the average length of stay when implemented, but it means that the staff has to work with this family, has to really support the family and integrate them into the care. So it's much more of a coaching method where the staff is really helping the parent to become more engaged with their child, more on top of what is this baby telling us? Are they really wanting to eat or they just need to be consoled? What's really the difference in their cues? How can we best help them to become more responsive to each other as a dyad? This is actually from the University of Arizona in their NICU. And this is their implementation model for how they put together how to support moms who are participating in Eat, Sleep, and Console. So they actually identify private rooms. I have seen this implemented in a single room design unit, but I've also seen it implemented here in San Antonio in a hospital where they put the baby and the mom, you know, out on the postpartum floor in a single room. So there's a lot of different ways, but it is about getting them some private space, some time to be together, but then having the right support from the staff. They do need a point of contact where they can get good information about NAS, where they can maybe share their story with others. So having a work group, really understanding what are the best ways to implement guidelines so that the whole staff is on the same page. And then of course, if you're getting these babies out of the newborn intensive care or out of the hospital sooner, having the right community outreach and support. So for example, one of the things that we're seeing happen in San Antonio is having a developmental follow-up clinic, particularly related to these infants' needs and their families' needs. Developing relationships with local inpatient rehab settings. So Casa Mia would be a great example of that, to which Dr. Cleveland's research has really developed Casa Mia to be a safe haven for these mothers and their infants, where they can develop a better relationship, a dyadic relationship, supporting each other. But this does take a lot of education and a lot of focus from those who are working with these infants and their families. So a core working group, both from the prenatal side, the in-hospital side, and then community outreach partners, really provides the best support for these families to be successful. This is one model. I know there are others out there, but I do think identifying right from the very beginning that you need to look at prenatal within the hospital and in the community is extremely important to being successful in supporting these infants and their families. So one of the things that the Eat, Sleep, and Console does is really coach the mothers during the feedings to help them. I put this picture here because this is not the ideal situation for recognizing infant cues, because the mother's not really going to be paying attention to the baby if they're on the phone. So I did put a not so positive picture up, but I wanted you to at least think about what that means. The mother really does need to recognize the infant cues. And so good nursing coaching would be about pointing out the cues or pointing out when the mother gets it correct, so that you're reinforcing her behavior or her ability to recognize her infant's cues. And then also not only to recognize hunger and discomfort, but also when they're satisfied, when they've had enough, when it's time to just relax. And encouraging the mother in a way that fosters her confidence. Coordinating feedings with mother's schedules, or really making sure that the mother understands the infant's schedule so she is available to feed her infant. And then offering as much praise to that mother for what she's able to do. Too often in the newborn intensive care, I'll see a mother, and it may not even be a mother who's working with the baby with NAS, but the mother is feeding the baby and things aren't going so well, and the nurse offers to finish the feeding. For me, that tells that family that the nurse can do a better job than that mom. And so we have to be really careful about how we inadvertently say you're not doing such a good job. So I really don't encourage that. I think we have to really think about the messages that we're sending. Helping them about timing, pacing, and avoiding interference with the feeding, like the phone use here. Multitasking during the feedings. Many of the times I see those who are feeding infants in the newborn intensive care unit, and they're feeding, but they're talking to everyone around them and not really paying attention to that infant. This is, I always say that breathe and eat are the two main goals of newborn intensive care. So feeding is really important. We need to be totally attentive. We also need to realize that we're also role modeling for families. They're watching us all the time. And so making sure that the message that we're sending by the attention we're paying to that feeding is also something we want to be aware of and be careful about. Feeding co-regulation, kind of how is the mother learning to anticipate, to participate, to really work with her infant. Making sure that if that baby is, gulping and really taking in too much air, how do we tip back that bottle a little bit to slow down that feeding? How do we kind of read that infant's cues, give them enough support and comfort so that they can relax during the feeding? So really making feeding an event we pay a lot of attention to, not just get through. The other intervention that I think we need to be paying attention to more with this population of infants is skin-to-skin holding. It has many positive effects, but for this particular population, the increased calming, the increased ability for the mother to get to know the cues of her infant, but also the increased milk supply that has been found to be related to skin-to-skin holding can be extremely important. The one thing that I would say is that particularly with these infants is to help parents, mothers, and fathers understand that if they're going to provide skin-to-skin holding, that they do it for at least an hour or more. The idea of getting in and out of the position can also be distracting for the infant and stressful. So the idea of, do you plan enough time and do you have enough support to really provide skin-to-skin holding? Most infants with NAS are term or near-term infants, and so we're not really as concerned about some of the other issues around skin-to-skin as we would be with a younger or more preterm infant. So it's really important to think about this as a population that probably could benefit from skin-to-skin as a way to increase parent engagement, increase calming for the infant, and increase the milk supply. There are barriers, though, to breastfeeding that are somewhat unique to the neonatal abstinence syndrome infant. And some of them are our own ways of thinking about whether these mothers are fit mothers to provide breast milk. And I think, that stigmatization can really be important to consider. Many units do lack guidelines for how do we manage human milk. So this was from the FAAN data from the work that I did with them a few years ago, where only about half of the units had a policy or a guideline to encourage breastfeeding or human milk for the NAS exposed infant. So I think it's important to think about what are our guidelines? Do we get them in place? And if there are guidelines, are they evidence-based? And so really making sure that all professionals are on the same page. The inconsistency about whether breastfeeding is safe or not safe, really having, even as a working group, those difficult discussions about why we believe it's unsafe or not, or is safe. I think having those can be really important to putting together the evidence or using the evidence to guide breastfeeding decisions. For the most part, unless the mom's excessively using, that is not gonna impact their breast milk. And so I think it's really important for us to be aware of, you know, what is the mom really doing? Are they here with the baby all the time and, you know, trying to consistently provide breast milk? And are they getting the support to do that? So these mothers often suffer from inconsistent professional advice. Some say it's better, some say it's worse. So really thinking about that. There are some intrinsic feeding challenges. We talked earlier about that disorganized sucking. These babies can sometimes more chew on the breast, really tug on it. So then you have a sore breast, which can really provide an increased or another type of challenge for the feeding to be successful. And oftentimes there's some separation. And I think about right now with COVID-19, how separation can really be an issue for providing human milk or breastfeeding for these babies. And of course, the prolonged hospitalization. And if the mother doesn't feel welcome in the unit, and if they feel that they're being looked at differently, then they're going to be less likely to visit. So really helping to make sure that we're encouraging, that we're welcoming, that we're not inspiring guilt, you know, for when they couldn't visit, really giving them the most support that we possibly can. Even so, the bottom line is that these babies are probably even less likely than other infants being discharged from newborn intensive care to go home receiving any human milk. Given what we know about human milk and breastfeeding, and I think about the microbiome and what's developing, these infants, I think, could truly benefit from the positive parts of breastfeeding. We have to figure out how to have a good guideline, how to work with the families, how to support them to understand why the breastfeeding is so important and why it would be important for them not to go back or have other drug use. Breastfeeding is associated with reduced severity of symptoms for NAS infants. It delays the onset of NAS symptoms. So really thinking about starting breastfeeding early within that first 24 hours or even 6 hours to actually make sure that we get good lactogenesis. But there has been several studies, and two that I'm sharing with you this morning, that show that there's a decrease in pharmacologic treatment, regardless of whether the infant is late preterm or term, or the type of drug they were exposed to. So really thinking about, you know, what are the cost benefits of providing human milk. Also, in this study, they looked at those who were predominantly breastfed and those who received combination feedings or were predominantly formula fed. And they found that the NAS scores decreased significantly in those who had been predominantly breastfed. So really thinking about how do we do that, and then looking at, you know, those who were exposed to methadone. Also, while some think that methadone contradicts breastfeeding, that actually has not been found to be the case. So really thinking about why are we what is the evidence to really implement good breastfeeding support in this population? So in conclusion, I think we need to know that infants with prenatal opioid exposure are difficult to feed, and they do require specialized nursing care to manage their withdrawal symptoms. We need to put a good plan in place. We need to identify and describe their specific characteristics. We need to help nurses have a good plan so that there's consistency across caregivers. We need to work to support the families to be involved in the feeding. We need to implement as much as we can an eat, sleep, console type of strategy for feeding. We need to really help parents to be involved, to encourage them to nurture that parent-infant relationship. All of these things can have a positive outcome, but we also need more research in this area. We really need to understand what works best with these families. As I've shown you, there are very, very few studies with very small samples. And so it's really hard to say that these outcomes, even those results from those studies, are meaningful. And so more research with these mothers and infants and their support from and coaching from the nursing staff is extremely important. I think I'm ready for questions.
Okay, great. I did send a chat for everybody to go ahead and send in your questions. I do already have one that was provided earlier, and this is from Lena. She is asking, is there any programs that offer support? Oh, hold on one second. One second. Sorry. Is there any programs that offer support education to mothers who want to breastfeed while on MMT without being judged or being told that it is not okay to breastfeed when taking methadone?
I do think there are programs out there. The University of Arizona that did the study on Eat, Sleep, and Console and is publishing another study related to that, has worked with those families. So I think being on methadone, actually, that's something we can control. We know what they're on. It doesn't really impact the breast milk in a way that's negative. So yes, there are programs. I think what we need to do is put that evidence together so that we can increase what should be like the process so that it's more consistency across programs. Because as you saw, I only was able to find, or they were only able to find 3 studies using the Eat, Sleep, and Console kind of methodology.
Okay, so and then somebody provided a comment based on that question, and it said WIC provides breastfeeding support pumps and IBCLCS.
Yeah, these mothers really do need lactation support. These infants are less likely to latch on appropriately, and there's more likely to be what I would call breast damage from the way their disorganized feeding is. And when there is breast damage, where there is going to be more pain for that mother, then the likelihood that they'll discontinue feeding is higher. So it's really important that we get them good lactation support, even in units where there are higher numbers of these infants. I think it's really important that the lactation support have increased experience with working particularly with strategies for this population.
All right, any more questions from the audience? Go ahead and send those in. Oh, it says somebody else commented also, there are 5 lactation centers in Texas staffed by several IBCLCSs.
Yeah, I think lactation support is so important for all high-risk infants, but particularly for this population, helping these mothers to gain support so that they are feeling increased confidence. Because I think once their confidence at being able to feel like they can be a good mother, they already feel bad. They're already not feeling like they've done, you know, people have told them they're not doing enough for their baby. They're not being as supportive as they could be. So it's really great to understand that these parents need their confidence built up. They need more praise. They need to feel that they're being successful. So the more we can do to create an environment where they do feel successful is where we're going to have the best outcome.
We have a comment from Lisa saying, great presentation, thank you. And then somebody gave a Texas Lactation Support Hotline number. It's in the chat. It's 855-550-6667. All right, one last call for any questions. All right, well, Dr. McGrath, I want to thank you so much for being a part of Texas NAS Awareness Month. We truly appreciate it, and we appreciate you being able to do the Zoom in place of the conference. Today would have been the last day of the conference in Houston, so we're so sad we didn't get to see everybody, but I think this provided some wonderful information for those that work in the NAS field and that are caring for these mothers and these beautiful babies. So we really do appreciate you.
Well, thank you. And I was really glad to be here to talk with you, to share some of the outcomes of the research that is happening, and to encourage you all to do more and share more about best ways to support these infants and families.
And I do have her presentation already loaded in the account, so that's there for anybody to reference. So, and they're saying great presentation, thank you. A lot of thank yous coming in. So everybody stay safe and have a good summer, and thank you very much.